Welcome to Arch Ghost, the show focused on creating high caliber, adaptable, and prosthetically driven full arch surgeons. The surgical techniques described and depicted in this podcast are provided by Arch Ghost LLC solely for informational and educational purposes and are intended exclusively for properly trained, licensed, and clinically competent healthcare practitioners acting within the scope of their professional credentials. As a licensed healthcare practitioner, you alone assume full responsibility for all clinical decisions, actions, and outcomes as part of your patient care. Please see our full legal disclaimer at archghost.com/disclaimer. Today, I want to talk about 5 freehand intraoperative ID points that you should be using. This is really specific to those surgeons who are doing freehand surgery, which is the way you should be doing full arch surgery, in my opinion. But I want to go over just a few key ID points that you can use intraoperatively to basically be your guide. Even though you're doing freehand surgery, these things are what you utilize to guide you. Now, there are more ID points than this. I actually gave a whole lecture recently on how to use multiple different ID points in freehand surgery. So this is just a little snippet to give you a little bit of a taste of some of the things that are out there that you can use in your surgeries. So the first measurement that I want to point out is one that is shockingly underused and just often not thought of, which is baffling to me. But that is the Edentulous midline measurement. And so what we're going to do here, forgive my artistic skills, but we're going to draw, this is going to represent the maxillary arch. I'm going to say this is the right maxillary sinus, the left maxillary sinus. Here's the nasal cavity, okay? So if we look at this particular case, and this is an edentulous patient, there's no teeth, right? The teeth would be here. Many providers feel that this case has to be guided because they don't know where to start their osteotomies because there really aren't sockets or other things to reference, and so they get lost. The easiest way that I've found to do this, there are a number of techniques, one of which includes making a hole in the sinus and finding the sinus and then going from there. I don't like that technique just because it makes a hole in the sinus. I just think it's unnecessary, but you can do that, but I think it's, again, unnecessary. All I do simply is I look at my CBCT Panorex image, not the 3D scan or the CT scan, but the actual Panorex image. And I look right in the midline of the arch, okay? And then I take my ruler on the CT scan and I mark at that midline, okay? And then I mark where I want to start my implant osteotomy. Now, basically, I place the implant first. I just visually, I place, maybe my implant's going to be here, okay? So maximum AP spread along that sinus wall there, exiting, on the ridge. Here would be your abutment. So I then take the ruler on the Panorex image and I just simply measure this distance from here to here. And this is usually going to be, let's say, something like, 25 millimeters. All right. Then intraoperatively, I simply take my sterile graphite device, mark the midline. I use a perio probe. I just lay the perio probe here, 20 millimeters, and then the perio probe I use is 20 millimeters in length. So I would mark, where that 20 millimeter mark was, and then I would lay the perio probe again and mark that additional 5 millimeters, and then I will mark, on the site here where that 25 millimeter mark is, and that's where I will start my osteotomy. Now, a couple of things. When I've shown this technique to some people, astute providers will say, well, this measurement is linear and the arch is curved, so it should be a curvy linear measurement, and that's not 100% accurate. And you are correct. It is not 100% accurate. This is a flat image and the arch is curved, and so there is some discrepancy there. Now, I can't tell you exactly what that discrepancy is. All I can tell you is it's accurate enough. I've done this hundreds of times. And if you've seen, the x-rays and things that I post with the implants, right along the sinus wall or whatever in an edentulous case, this is how I do it. I'm not using a guide. I'm not poking a hole in the sinus. I'm measuring it on the pano and then transferring that measurement to the arch clinically. Now, I will say that a key to doing this is that you use what I call the low RPM osteotomy technique. And you can find that on my website. It's an article, a blog article. But the very short summary of that is you need to drill these osteotomies slowly to ensure that you can feel if you are popping into the sinus. And you can confirm your anatomical location by the feel of your drill. So I use this to get me 90% of the way there, but I also clinically confirm with the feel of my drill and a perio probe placed in the osteotomy to make sure that I haven't popped into the sinus, okay? And maybe there are some times where that needs to be adjusted slightly, a couple millimeters one way or the other, but it's really pretty accurate. But again, I wouldn't just then blindly go and not pay attention to anything. You need to also confirm that location by clinical tactile feedback. But that's what I do. One thing that I want to point out here is how to interpret these measurements, right? So when you look at a Panorex and you take this measurement, if this measurement is 20 millimeters or less, 20 millimeters in most cases is going to correspond to where a canine would be located on most patients. Obviously, everybody's arch is different. I'm just taking the average patient. The reason I know that is because I've measured a bunch of different panos to see where that comes out, and it's typically around the canine area. So that means if you're getting this distance from here to be 20 millimeters or less, that's not enough. That's a canine spread. And that tells you that you likely will need some other implant. What that is depends on the case. Does it have to be a pterygoid? Is there a palatal root? Is there a transpalatal? Whatever. But that gives you that feedback that you're probably not good from a spread standpoint. If this measurement is 25 millimeters-ish, if it's around 25 millimeters, that's usually going to be somewhere around a first bicuspid position, okay? That is like the gray area, right? So in some patients, maybe that's enough. In other patients, maybe not, depending on the cantilever, the arch size, it's the patient a Bruxer or whatever. And also, maybe are you going to shorten the arch or use a smaller arch? What's your torque value? All those things come to play a part when you're at a first bicuspid position. But you know that 25 millimeters is going to be somewhere around that first bi. Now, when this distance from here to that midline is around 30 millimeters-ish, okay? That's typically second bi or sometimes even better, all right? So there you're golden, right, in my opinion. If you can get back to that second bicuspid position for a first molar prosthetic, you don't need an additional implant posterior to that. A typical 4-implant configuration is normally adequate, and you know that you're going to be there from a planning standpoint. So a good way to look at that x-ray and tell that quickly. All right, so that's your ID point for the first one, and that's basically just that edentulous midline measurement. Now, let's take a look at the second ID point, which is a socket or a defect. Now, this to me seems obvious, but many people don't use these as identification points, it's like the lowest hanging fruit out there for planning a case. So paying attention to where your sockets are and where defects are create a huge advantage. So I'm going to draw that arch again. Let's say this side has a little bit of a defect, maybe a couple defects there. And then this side is going to have it has just one tooth. Okay, so I have to draw a lot. It has a second bicuspid. Now you've got your sinuses here, your nasal cavity here, sinus here. Okay. Now, in this scenario, when you look at this case, to me, this case is extremely easy to plan because you have a built-in guide. Okay. On your left side, this is the second bicuspid. You already know if you're in that socket with your implant placement, you angle at 30 degrees, right? Implant goes right here. You know that you're going to be in a strong spread position. You're going to have a limited cantilever, and you know you're going to avoid the sinus. Got your sinus right here. You're in front of the sinus if you're in that socket. That's all you need to know. You don't need any other guide. You know where you are by that tooth position. Now, on this right side, you might say, well, I don't have a tooth position. Now, the key here on the right side is we've got these. Look at these little defects in the bone, and you'll see these on the panel or on the CT. Now, when I look at that, I see this and I say, perfect. Look at where those are located. If I'm just behind that bump with my implant, I know I'll avoid the sinus. I'll be in a strong spread position. If I have concern, I can measure like we talked about. Okay, this is 30 millimeters. I know that's a second bi. Okay, so I'm good from that standpoint. So being able to see and utilize those defects is, again, there is not a better guide. You can fabricate your own guide, and you want to have as much accuracy as that. That provides you everything you need. Now, here's one key, though. When you're going to use this technique, what you've got to do intraoperatively is you've got to draw your implant line, and I'll say this is my sterile graphite device. I'll draw my implant positions here. Here I do a modified V4, and I'm going to do it here at this socket, okay? Now, I'm going to draw those lines clinically with the sterile graphite device before I perform my reduction. The reason that I'm going to do that is after you do your reduction, if this red line is going to come through here, I guess it's not squiggly because we want a smooth line, but if you're going to do your reduction and you reduce across here, guess what happens? Now on the left side, you'll have a little bit of the socket left. On the right side, you'll no longer see this. And this is what I see a lot of surgeons do, even experienced surgeons. They do the reduction before they mark their line. And then they come back and say, well, now I don't know where I should go. And that's why they put a hole in the sinus or use a guide or other things when the guide was right here. It was right here to start with, but you removed the guide before you used it. So use the guide first, mark your line, and then do your reduction. And that will be the game changer for you. So socket or a defect is highly advantageous and is the lowest hanging fruit out there that you can use. All right, that was number 2. Number 3, the canine apex. This is something that I think is extremely valuable that I haven't ever seen anybody else use. I just started doing this at some point, and I don't know why or how, but it has become extremely beneficial. And that is, okay, if we look at our arch, our sinus, nasal cavity. Now, if you look at most canine sockets, this isn't always the case, but many, many, many of them, especially in atrophic cases where the sinus has become pneumatized, that sinus will come down and touch the apex of that canine socket, okay? So this outline here is that canine socket. This would be number 6. This would be number 11. And so again, what you can do intraoperatively is if you have a canine socket and you're trying to maximize your spread, maybe it's a pneumatized sinus case, you can really stretch that implant position really far back. And as long as you see that implant drill pass through the tip of that canine apex socket, you know that you're not in the sinus. If you do this case, now there's some experienced caveats to this where you can be palatable to the socket, but just for the sake of this talk, if you do this case and you do not see your drill pass through that apex, this is likely where you are. You're likely going to be in the sinus, okay? The correction then, if you do feel that you drop into the sinus or you don't see your drill, instead of just saying, now I don't know what to do, I'm uncertain where I am, just redirect your drill until you see it pop through the apex of that socket. You'll see this come through when you look in the socket, and now you know where you are. So it's just a simple tool, and the benefit to this is that canine socket is when the sinus pneumatizes, and when you have cases where you really need this, it's almost always touching the sinus because that pneumatized sinus has come down to the area of that socket, but it's not going to erode the socket, right? So it comes up and pushes on that lateral wall of the socket. So very beneficial ID point, especially when you're trying to really stretch spread in an atrophic case. Now, next ID point, number 4. All right. We're going to go down to the mandible. This one, let's see if I can draw a mandible. I don't know. So, a little bit lopsided. All right. Not the best mandible, but got your mental frame in. Okay. So, the mandible, there's 2 ID points that are great to use. The first is the apex of the mandibular central incisor socket. When you see the mandibular teeth, the central incisor sockets, that's maybe lateral, maybe central, lateral, and then we'll say canine, something like that. So almost always, now never say always, right? Almost always, when you perform your reduction, if you are going to be to an adequate depth of reduction for the average prosthetic, which is typically at least 15 millimeters of space, you are almost always going to reduce to the point where you've completely eliminated the central incisor sockets. You may have a small amount of the lateral incisor sockets available, and you'll have the canine socket, obviously, it's so long. But those central incisors, they're almost always going to be gone. So now, again, there are going to be cases that are either maybe some of it's still there or you need significantly more depending on the reduction requirements. But the vast majority of cases, you'll reduce down to the point where you just eliminate those central incisor sockets. So the key to this landmark is just that shouldn't be your only measurement. I do have an article on the website that teaches you how you should be checking your reduction intraoperatively, but this is just an ID point so that you can tell, even if you took a measurement, if you have a significant amount of that socket left, you might say, you know what, I need to double check that, because usually that's not the case. So that's the real key there. The second, or not the second, but our fifth and final ID point that you should be using intraoperatively is the mandibular external oblique ridge. And when you look at the jaw, that's that little area of bone that kind of tracks right down here and kind of right down here. And it's a ridge or a ledge, okay, the external oblique ridge. The benefit to that is that if you draw a magical line that kind of follows that around, what you'll see is that, again, almost always, never say always, but almost always, it will very closely mimic a 15-ish millimeter reduction. And this is a great way to, quickly reference or visualize your reduction. I'm not saying that this should be the only thing that you use. You should be, performing actual measurements intraoperatively. But this is, again, something that you can just get a quick reference point, understanding, where you're at. Are you way below that point? Did you over-reduce? Are you planning your initial reduction line way above that point? It's probably going to be insufficient. So again, just a reference point for a quick visual assessment. So that's it. There are many more reduction points. We don't have time to go over them all today. We'll cover those at another time, and definitely all things that we cover in our Arch Ghost courses. But 5 key points that I think you really should be using: the Edentulous midline measurement, any socket or defect, the canine apex, the apex of the mandibular central incisor socket, and the external oblique ridge. Okay, so that's the pod. Always remember, operate in the shadows, adapt relentlessly, load them all.